Okay, this is week 14, should be week 14, for wound care. I'm going to go over some anatomy, anatomy of skin around the wounds, wound terminology, certain phrases around wound healing, and then kind of a basic kind of clinical evaluation of a wound and how you would do some basic treatment concepts around wounds. These are kinds of things that a hand therapist sees a lot. It's very much a specialty kind of thing. General outpatient clinic, as an OT, you're probably not going to see a lot of wounds. You may see some kind of wounds. But as a CHT, you're going to see a ton of wounds. They're going to be coming right out of surgery, dealing with all kinds of things that you can possibly imagine. You have to really be kind of an expert at this. And I think there's a lot of opportunity for OTs to get into this and get a lot of different job opportunities. Learning objectives. What are the phases of wound healing? What factors inhibit wound healing? What are signs of infection? What are the signs of a too wet or too dry wound? It's going to be a key concept here. If it's too wet and basically just looks too wet, too moist, especially right in the middle of the wound, the Peri area, or it's just too dry. It looks very dry. You have to kind of balance it out so it's not too wet, not too dry. A big part of what you're doing is in wound care. The layers of the skin. This is kind of basic stuff. Goes back to A and P. The epidermis, the outer layer, the dermis, the middle layer, and the hypodermis, and the fat cushioning layer. A lot of your pressure wounds can happen down in this area. The epidermis, again, this outer layer. It's the outermost. It's the thinnest layer of skin. No blood vessels present. Kind of like a waterproof barrier. It determines your skin tone as well, the melanocytes. Epidermis is like a thin rain jacket used to protect yourself against the rain. Kind of think of it that way. And you go below that to the dermis. It's kind of connected to the epidermis by the basal membrane. Contains tough connective tissue, hair follicles, sweat glands, nerve cells, lymph vessels. It's highly vascularized. A lot of blood flows through there. Regulates your body temperature. If you cut yourself and it bleeds, you've cut into the dermis layer of your skin. Hypodermis, subcutaneous fat. This is the deeper bottom layer. Made of fat, connective tissue. Provides like a padding and protection to the muscles and fascia. It is the cushion of the deeper layers of the body. We have those deeper soft tissue structures that we're always kind of concerned about. The muscles, the tendons, the fascia, veins and arteries, definitely those nerves as well. This deeper area along the hypodermis is most prone to ischemia. Ischemia, lack of blood flow. Keep going back to that space and flow kind of thing around upper extremity stuff. Most prone to ischemia is where pressure wounds begin. Terminology, different stages of healing around wounds. This doesn't look at, but this is actually a very good stage. This is called granulation. Consists of a new connective tissue and microscopic blood vessels. The first good stage of wound healing is granulation. Grows in the base of the wound. It's able to fill wounds almost any size. It's usually like a Lux, beef, ready, shiny, nubby kind of thing. Granulation is a good thing. It is the beginning of a healthy wound bed. This is what you want in wound care. And then based off that granulation, the next stage up is something called epithelialization. This is kind of an amazing thing the body does. Epithelial cells, they kind of migrate, or they kind of move across the new tissue to form a barrier between the wound and the environment. They're starting to protect it, kind of closing it up, so to speak, closing up with the wound. Epithelialization is what keeps the moisture in the wound, as well as acts as a barrier to keep bacteria and all that bad stuff out. This little graphic shows the cells kind of migrating into the wound bed to kind of close it up, get that protective barrier in there. More on epithelialization. The formation of granulation tissue into an open window allows the epithelialization phase to take place. It lays the groundwork for the skin cells to migrate across the wound bed for healing. Epithelialization happens at the base of the wound and slowly migrates outward. Starting to happen here. So starting to close in. This is the bad stuff. We're going to get the next two things. Something called Exudate. Kind of an example of it. It's kind of exuded from the tissues and capillaries. It's caustic to surrounding skin, and so we need to remove it. One of the things you're doing is in wound care is removing the exudate if you can. It's high in protein and white blood cells, different types, 4 different main types: sanguinous, serous, serosanguinous. I'm not sure I pronounced these right. Purulent. Different tinges to them. Again, the main objective is this is in wound care is to remove those. Slough is something else you need to remove. It's caustic to surrounding tissue as the exudate is. Looks like signs of infection, but it's really just dead tissue that needs to be removed. In appearance, it looks like soft, moist, necrotic tissue, maybe white, yellow, tan, or green, slimy, wet, slippery, high in pH. Then there's something called eschar. It looks sort of like a scab, but it's not a scab. If you've ever seen eschar, you'll never forget it. It's just very, very black, just like it looks right here. Thick, leathery, necrotic tissue or dead tissue. Usually brown or black. It is flush with the wound. And it's not a scab. Scabs are dried blood and serum that sits on top of the skin. This is kind of like flush with it. A wound with slough and eschar cannot heal unless the necrotic tissues are removed. Here are the different phases of wound healing. You have that inflammatory stage for 5 days, proliferative fibromyalgia stage 4 to 24, and that remodeling scar maturation stage 21 to 2 years. Breaking these down. The inflammatory stage, those first 5 days, obviously a lot of swelling, clotting, vasoconstriction, bleeding new blood cells, dilation, non-injured cells, phagocytosis, cellular removal of the dead tissue. It does this by kind of eating it up, kind of gets rid of it on its own, and then all that edema, redness, and heat. And kind of moving on to this proliferative stage. This is when you get into the granulation and the epithelialization. Granulation of tissue, like the wound bed, cells migrating across the wound bed, kind of starting to close it up, forming new tissue, collagen production, growing of blood cells, building the tissue framework, scaffolding for wound healing, and it starts to contract, starts to kind of close in. These are all very, very good things in a healthy wound recovery. This is kind of this latter stage, this kind of remodeling, scar maturation stage. Starts around 21 days, goes up to 2 years. Collagen fibers increase in form, bulk, and structure to increase tensile strength of tissues. Scar changes in appearance from red and raised to pale and flat. When it's red and raised, that's kind of a good time, if possible, to start ranging it, stretching it. It's supposed to be like with the burn wounds. A huge deal with burn wounds is getting the range of motion back. You can get contracted, deformed really quickly, really easily. And one of our big tasks as OTs is to get that range back. This is a good time to start doing that, right around 21 days, generally speaking. Factors that impede wound healing. This is something you have to kind of really be aware of. Definitely, the older the person is, the more harder it's going to be to heal some wounds. Some wounds, people die of them, like pressure wounds. They can never get them fully healed. This too dry, too wet thing that we talked about. We'll talk more about that. These are the things that slow down the healing. If it's too wet, you have to kind of dry it out as a therapist. Or too dry, get it more moist, swelling, nerve sensory impairments, decreased blood supply. This is a huge one. We talked about the Allen's test, how much blood is flowing into the hand. Things that decrease blood supply, excessive caffeine, nicotine, pressure, like a splint that's pressuring a point, wound site tension, definitely diabetes, immune suppressed, certain medications, cancer treatment can all impede healing. Different kinds of wound closures, how they close the wound. Primary intention, surgical closure of the wound, closing it up, suture, staples, steri-strip. See this a lot with total hips, total knees. They'll come home with the staples, and sometimes the PT will actually remove the staples in the home. Secondary intention, kind of heals from the inside out. Kind of naturally does this. This type of closure, there is a greater likelihood of scarring because there's a greater surface area for the scar tissue to form. Kind of goes through different stages. You can see kind of the lasting scar, not that really bad on that one. Delayed wound closure. This is kind of different. So it lets it open for like 3 to 5 days, do some healing, open air kind of thing, and then it closes it up. Steri-strip kind of closure. Common with fasciotomy, surgical cut to remove pressure, swelling due to compartment syndrome. So compartment syndrome, you may have heard of this. It's like internal pressure inside the wound from bleeding and swelling, and it kind of starts to swell up. And what they do is they cut it, open it up, leave it open for a few days, and then they close it back up. Typical kinds of wounds you're going to see in the clinic, a lot of lacerations, grafts, and flaps. Skin graft is kind of what it says, the transfer of a portion of the skin without the blood supply. That's the key thing with the skin graft. To a wound, such as harvesting of skin to facilitate healing with a burn. A flap consists of one or more tissues from a donor site. Could include skin or deeper tissues, muscle and bone, that is still receiving blood supply. Some of the stuff you're seeing typically in the clinic, surgical closure of a wound laceration. This looks like a flexor tendon repair, that zigzag kind of thing. Skin graft, it's grafted some skin. Donor site, a lot of times they take it from the person's legs. Pin site, we talked about those external fixators. Here's a different kind of pin site right there. This is a different kind of wound. As an OT, as a therapist, you have to really watch that site for infection and keeping it healthy. Traumatic wounds, pressure wounds. These are the ones that can be so devastating, especially to older folks. They can get so deep into the bone. Splints can cause pressure wounds if they're not fitted right. Just laying down in bed can cause pressure wounds on certain spots. Sitting in a wheelchair all day without the right cushioning can cause pressure wounds. Other wounds, this is awful burn injury from I believe this is the 7-month-old baby that Andrew was telling me about. I think it's distorted, the picture, in terms of how big the hand is. But this baby had a full recovery after touching a wood stove. So it's a good news kind of thing. This is frostbite. This can be wicked nasty as well. See some of that. How do you evaluate these wounds, just generally speaking? Obviously the history of the wound, how did it take place, and all that sort of stuff. Size, placement, skin temperature is important. The color around the wound. Is it healthy? Red is healthy. Yellow, getting some necrotic kind of stuff going on. Black, not good, generally speaking. The color, texture, odor. Sometimes it stinks, especially if it's infected. It will start to stink. How moist or dry is it? How much swelling is there around it? Your goals as a hand therapist working with a wound, obviously to close the wound, minimize the impact on range of motion and function, go after that edema. Some general kind of rules of thumb: if it's red, to keep it moist to promote healing. Yellow, kind of bad stuff, kind of the exudate, kind of get rid of all that, to facilitate healing. Black, thorough debridement, need some help from the team to kind of debride it. Sharp debridement with a scalpel. I mean, not pulling it out by hand with the gloves, but with a scalpel. OTs in Maine can't do that. They may be able to do that. I think they can do that in other states, but in Maine you cannot use a scalpel to kind of debride like an eschar or something in the infection. Debridement, different kinds of debridement, talking about debridement. The surgical, mechanical, chemical, these kinds of things. Do some of this. Autolytic. You selectively use the body's own white blood cells and enzymes with moisture retentive dressings. This is really high-level stuff. Getting to different kinds of dressings. The Tegaderm, Tegagel, Duoderm, collagen. Some OTs are really into this, but it is, again, a specialty kind of thing. Typical wound supplies the hand therapist is working with. Adaptic, moist, non-adherent dressing. Zero-form, moist, non-adherent dressing. Gauze, Tefla, saline to kind of wash out the wounds along with the peroxide. Gloves, obviously, and coverings. Camera. Andrea, the CHD, always has a camera, so she's taking pictures of these wounds. This is very common in wound care. Nurses do this. I saw a lot in home health. They're taking pictures of the wounds so they can give it to a wound expert. They can show the healing, get at all the issues that are going on. It can be a very skilled kind of thing, wound care. This is the sequence. Typical, a wound comes into the clinic. What do you do? How do you kind of break it down? Obviously, sterile gloves. Take off the dressing. Clean the area with a saline, a 50-50 saline and peroxide mix. There's an exudate present, and remove that. Saline soaked gauze or cotton swab. Document everything. Redress it for moisture kind of balance. Dressing should protect the wound, support surrounding tissues, and maintain that moisture balance. Again, this is a key part of all this. We want it to be just right. We don't want it to be too dry. Think of it as a plant. This may help you think about it. You don't want your plant to be too dry or too wet. It's just right. It's gonna thrive, be all green and grow and flower and all those great things. If it's too dry, it just looks dry. Dry does have a wound painful, slower healing. Too wet, a lot of moisture, or around the peri wound. This is like the very center of the wound. Possible increases in wound size, slower healing. This you think, I'm not really sure what's too dry, what's too wet. Again, it comes with experience. I'm giving a general outline, a kind of a general kind of framework, understanding to kind of jump into this if you're thrown into this, and then you're just going to learn from your CI or your boss on the job, especially a wound. It's like a skill you're doing, learning as you're doing. You can't really learn it through a PowerPoint or through a book. Generally speaking, some things you can do if it's too moist. All these different things, the Adaptec, the Xerophone, the Bacterian, only cover immediate wound area. Excessive moisture slows down. You have to be really careful about not putting too much. Once the wound is fully epithelialized or fully closed, no longer needs moist bandages. Too much. Too wet. Allow air to dry. Then cover with a non-adherent air permeable bandage. Okay, so it's letting it air dry, and then a non-adherent air permeable bandage, such as Teflon. Infection. This is something everywhere all the time, not just a hand clinic. You need to be kind of on the lookout for. This looks infected. It's red, it's swollen, two huge things. Could be a lot of extra discharge, could stink, the redness, delayed healing, increased pain. I would suspect this person is getting increased pain, definitely increased edema. You touch it, and it's warm. And they may even have a fever. A lot of times you're taking their temperature to see if they have a fever. These are some different clinical cases. This was a skin graft, stuck their hand into an open fire. That's kind of how it looked early on. Third-degree burn. Third-degree burn, there's no pain. Some wounds left open. You can see through there to heal. And there was some edema present. How did they treat it? Keep the red wounds moist, protected, but left the wounds open to air. So moisture with different wraps, leaving some of it open to air. This is how it kind of progressed, this to this. So that was a pretty good outcome with that one, as you were saying. With this one, how would you treat this? From my perspective, looking at this, the first thing I'm thinking of, peri wound, right in the middle here, we can look at it. Very moist. almost too moist. I want to dry it out some. And then there's the Exudate. At least this Peri area I'm going to be cleaning off. I'm not sure how much this I could clean off, but this I would definitely take off, clean it off. So dry it out, clean it out a little bit. This one definitely has this like the slough. I'm going to be taking that off. And that's, again, definitely the tissue when I remove that. What is going on with this one? I had to guess. To me, it looks like infection. It's just red and it's swelling. Red swelling, kind of like a red flag. If you ever had an infection, I've seen somebody with an infection, you kind of know. But again, you'll see this more, a lot in the clinic, and I'm going to clue you in. Okay, what are the phases of wound healing? Let's go back for that one. I make it easy. It's that big graphic, the inflammation and all that. So it's inflammation, 0 to 5, proliferative, 4 to 24 days, and then remodeling scar maturation, 21 days. What factors inhibit healing? Certain medical conditions, diabetes pops into mind, too wet, too dry, blood flow, those sorts of things. What are the signs of infection? We just kind of talked about that. Red, swelling, painful, increased pain, could be increased discharge, could be warm to the touch, that could have an increased temperature. What are signs of a too wet or too dry wound? Too wet around the Peri area, excessive moisture. You could do that with certain kinds of wraps that would draw out the moisture. Too dry, again, it just looks too dry within the Peri area, cracking, that sort of thing. Treat that with moisture wraps. Going back to too wet, you'd have those. You want to let it. It's too wet. You want to give it to the air. Give it some air as much as possible. Those wraps that have air permeability to them would be good for the too wet. Too dry, you're just kind of sucking up. You're doing wraps that will kind of suck up that kind of fluid. That one, I'm going to make it easy again. Maybe go down to that one. Non-adherent permeable bandage. That's really good for the moisture, along with air. Just cover the immediate wound area. Excessive moisture slows down the healing process. Different kinds of wraps here. The adaptic zero foam. So that is all those. And that is that lecture.